I'm Shannnon Senefeld. I'm the Global Director for Health and HIV at Catholic Relief Services. So I thought I'd start off by just telling you a little bit about myself personally and who I am and why I'm involved in this work and how I got involved in this work. I have a hard time defining myself these days and defining my own identity in terms of what comes first. And I find myself oftentimes in professional situations introducing myself first and foremost as a wife and a mother, and then realizing that wasn't what people meant. They actually meant what do I do as a profession, not like who am I? And I think, we change as we go along throughout our lives, and as we mature over time about how we define ourselves. I still define myself first and foremost as a mother, a wife, and also then I have my professional work in which I am a licensed clinical psychologist and, of course, within my work at Catholic Relief Services. I'm a proud mother of 3 children. So we were talking about this earlier. I have a 7-year-old, a 5-year-old, and a 3-month-old. And I think that they give me new inspiration every day. And I definitely got into this work way before I had children, but my motivation all along was always that I wanted to help others. I wanted to be able to give back. And part of that is based on my faith and where I come from and the faith that underpins my work at Catholic Relief Services. The idea of justice and human dignity and the idea that we're always supposed to reach out and help the poorest and the most vulnerable. And so for me, that's been a really driving motivator. I feel like I've really been called into this work to really make a difference in the long term. And I hope that I'm also teaching my children to do that over time as well. Oftentimes my daughter will say to me, Mommy, don't go. Do you have to go? Do you have to go on this trip to Africa? Do you have to do this? And I'll say, right, but remember what Mommy's doing. Mommy's going to go and she's going to help all these other children or these other people who don't have as much as we have. And then she says, fine. Okay. Because it's important that they're also learning that they can't be selfish at this point, and that we all have to give back, and how we give back varies. It varies if you're an adult and if you're in a profession that you can give back. If you're a child, you can give back too. You share your mom a little bit, you share your dad a little bit. And so there are all kinds of ways that we can all give back. And I think that this idea of this global network, this global platform where we can all bring together all of our collective giving back and moving forward, that gives us a lot of collective power and ability to move things forward. So I'm very excited to see this moving forward myself. My son woke up this morning and he said something that I thought was really great, and I think I want to carry it with me forever. I always ask my kids jokingly in the morning, did you wake up on the right side of bed? And he always takes it very literally and says, Mommy, I can only get out of one side of bed because the other side's against the wall. And so this morning he woke up and he said, Mom, you know what? I think I woke up on the right side of life. And I said, I think that's great. I think we should all wake up on the right side of life, and if we find that life doesn't look right from where we wake up, then maybe we need to do something, and we need to hold ourselves responsible for making sure that it does start to look right. So I started with CRS, with Catholic Relief Services, 13 years ago, and I started overseas. I started my career overseas in Haiti with them, working on maternal child health programs, actually in an emergency setting. And over that time, I've spent also time with the U.S. government, working in Zambia, with Catholic Relief Services in Haiti, and then for several years, and also in sub-Saharan Africa, where I worked on a number of HIV and health programs in our sub-Saharan African office. I also did some short-term health work in our Eastern European office, and I've been supporting our Asia offices as well. So for the past 7 years, I've been based back here in our headquarters office in Baltimore. Just a little bit about Catholic Relief Services and who we are. We were founded in 1943 by the United States Catholic Conference of Bishops. So we're the overseas development arm of the United States Catholic Conference of Bishops. You might be more familiar with Catholic Charities. A lot of folks have heard of Catholic Charities. They're the folks who do the work domestically, and we're the ones who are doing it overseas. So they're our sister organization. We work very closely with them. We currently operate in about 100 countries around the world. And as I said, I'm more focused on the health and HIV work that we do. Our health and HIV work is in about 60 of those countries, and we had about 40 million beneficiaries last year within those health and HIV programs. Our focus is always on the poorest and the most vulnerable. So wherever we work, I think what we're trying to do is to look at these key principles that underpin our work around Catholic social teaching, the idea of a just society, the idea of a right society, the idea of social justice, the idea that we are responsible collectively to help the poorest and the most vulnerable. And so that always underpins our work. Unfortunately, in many situations, the most vulnerable are women. And so we often find ourselves addressing women and related issues in our work. And I cringe whenever I hear women's issues, because I think that Paige hit it right on the head earlier. It's never just a woman's issue. This is a collective issue that we all have to deal with, and we have to change this larger culture and create a larger enabling environment, because it's not just a women's issue. It's much larger than that, and I hate to see us just silo into that. So that really underpins our work. I think I've personally been inspired by what I've seen on the ground and in our programs for years, not only in our programs, but the work that's being done by faith-based organizations and other faith organizations. It's truly inspiring. One of the areas where we've worked a lot is on HIV, and I know Debbie just mentioned a lot of this. One of the things that we saw happening over the past years has been an increasing feminization of HIV, where more and more women are infected with HIV more frequently than men. There are a lot of reasons for this. There are biological reasons, women are more susceptible, et cetera, but it's all exacerbated by a lot of the cultural and social reasons that exist. In sub-Saharan Africa, we see, and you mentioned that most certainly infected by her husband. Well, we frequently see that increasing rates of HIV infection are occurring within marriages, from their husbands to their wives. So because of because of infidelity, we're seeing an increasing rate of HIV transmission within those marriages. So that's just horrifying, right? I mean, who wants to think that you're promoting women to take care of their health and to do all these things, and then all of a sudden they're becoming infected because they're remaining faithful in their marriage, and their husband brings something like that home. It really eats away at that very fabric of trust that's within the marriage and that marital relationship, and then it destroys the entire family. So we've been, just to share that there are some solutions, not that it's all dark and gloomy. I think there are things we can do if we start to work together. So one of the things that we've been doing in collaboration with Maternal Life International in Uganda is looking at how we can go back to some of those traditional strongholds that exist. So how do you build on the strong traditions that are there? I think tradition does have a hold, and loyalty does have a hold. But if we can look at some of the positive holds that exist, and if we can translate those into positive action and build those up, rather than trying to always just change the negative, then we have a much greater chance of success. So one of the things that we've done with Maternal Life International in Uganda is actually look at how we can build on those traditions that exist, which were faith-based. So traditionally in Africa, there was a very strong faith, right? There was a very strong faith movement. There was the idea that you should be listening to the church, that the church is important, regardless of your faith, that the church is important, that the spiritual leaders are important, that you should be coming together collectively. So we went back to that and we said, okay, what are these traditional faith beliefs that exist that we could use today in our work? And we created a curriculum called the Faithful House. And it's about increasing couples' communication, increasing skills within the marriage and the relationship so that both partners understand the importance of fidelity, they understand pressing issues that contribute to inequity within the relationship and unjust or not right relationships. And so it's really going back to what did they see? What traditionally was appropriate, and how has that changed over time? And how can we go back to some of those strong tenets that are there and in place? So for us, I think it's been really critical, because one of the things that we've seen in those relationships is that both men and women are reporting afterward that they're seeing success, they're seeing changes, success as we would define it. They're seeing changes in their relationship. More frequently, women are now involved in decision-making matters about healthcare, accessing healthcare, about financial resources within the household, about all of those things that are critical in terms of giving women more of a voice and making sure that their voice is heard within that relationship. So I think that that's just one example. We started our HIV work in 1989 in Uganda. It was our first project that we worked in. And it was due to the sister who was in charge of our health portfolio at that time in our headquarters office, Sister Ann. She actually went out and she was visiting the local church partners, and she found that they were doing a lot of home-based care for people who were dying, and who were dying in very undignified ways, without appropriate palliative care, without appropriate support, oftentimes isolated, alienated, considered an outcast for various reasons. And unfortunately, many of these were women. So she went out and she saw these, and she met a woman called Faustina. And Faustina shared her story about how she'd been infected with HIV, and how she had been left alone to die at the end because she didn't have anyone to care for her. So Sister Anne came back and she was really motivated, and she created what was called our Faustina Fund, and that's kind of been how we've moved forward with HIV programming throughout our history since then, since 1989, which I think is super fantastic that Faustina was able to inspire such movement and inspire us to do work so that we could look at how we could provide more dignified response to those who were in need throughout the lifespan, all the way before birth, all the way to death. So not just zeroing in on one aspect or the other, but how do we provide that dignity across the lifespan, and how do we make sure that we're really drawing on the local fabric and the community that's there to do it. In Ethiopia, we have another project just to share, because you talked about the female genital mutilation. And in Ethiopia, adolescent girls, about 75% of them experience female genital mutilation across the country. So it's a huge issue. And we know that it's an issue. But at the same time, the girls are oftentimes promised for marriage when they're born. So if the family is promised that they will provide the daughter when she's a baby to the family down the road, then that family down the road has been providing economic incentive. They've been paying for the daughter's health care, her education, if anything was invested, etc. So by the time she turns 14, 15 years old, and she's ready to be married, if her family then backs out, they have to return all of that money. And these are oftentimes families that are just economically, they can't do it. How could they repay that amount of money? So one of the things that we did was go in and start looking at the overall culture. How can we start changing the way that things are looked at so that perhaps you don't have to engage in early marriage contracts straight from birth? Could the communities come together to start talking about other options that would avoid early marriage, that would provide options for waiting? Because we know that the earlier the marriage happens, the poorer the health outcomes are over time, both for that girl and her subsequent children. So it's just a cycle that's going to repeat itself over and over again. So how can we start slowing that cycle and really looking at making a difference? So we went in and we started having conversations with the community to see what they would recommend. Do they see this as a problem? What do they think is going on? And amazingly enough, a lot of the men came forward and they were like, yeah, this is really an issue, but we don't know how to stop this because it's the only way we can really get our girls to have access to education. And the girls were saying, well, we don't have a voice. We can't say no. We can't say what we want to have happen. So we looked at different ways to say, how can we empower the communities? And that starts from an economic perspective as well. How can we empower those households to make different decisions? So we started doing a lot of the savings-led groups. We started giving girls access to land, community land that they could actually use. So the adolescent girls were actually given this land, which was valued by the community. So suddenly the adolescent girls had something that was valuable. And so all of a sudden their opinions were more valued. And a lot of fathers actually started standing up and saying, I'm going to be a role model and I'm going to say no. I'm going to say no to early marriage. And if I say no, then maybe my neighbor will say no. And maybe it's just that we need that spark to actually start making a difference. We need a couple of champions in our neighborhood and our communities to stand up and say, this is going to be different, and I'm going to be the first one to see it change. And it's really been working. I mean, it's been fantastic to see that this is actually happening, that the communities are changing the way that they're working, that the fathers are taking more responsibility, that the girls now feel empowered, that they can actually speak because they're valued in the community. They have valuable input, and they see that now for the kind of this first time. It's like, oh yeah, we do have something to say, and somebody's actually listening. So I think that that's been fantastic. Just also to build on the issue that was raised earlier around maternal health, this is a huge problem. And I know, Paige, you mentioned with the Kenya study that we need to look at how we can roll out different mechanisms to get women in for care, to make sure that they're not being attended to by unskilled labor or even by themselves without any labor whatsoever. One of the things that we've done in Nicaragua is actually through a project funded by USAID, we had to come up with an innovation, and our innovation was men's involvement in birth. So I know that sounds almost bizarre, but that was the innovation, that men would actually be involved in pregnancy and childbirth, because it used to be just considered a women's issue. And so we started looking at how can we engage the men in the community so that they actually were seeing themselves as having a role to accompany their wives throughout that entire pregnancy, and then ensuring that she actually got to the center of the clinic on time for the delivery. So before, the women were encouraged to still go get the water, which might have been an hour, 2 hours away every day, even all the way up into their 9th month. So oftentimes they would go into labor when they were far away from home. They didn't have time to get to the clinic, et cetera. So really changing some of that culture so that men would say, maybe I could actually get the firewood, or I will go to the river and get the water when my wife is 8 or 9 months pregnant. Maybe I can do some of those things and then make sure that she's actually being assisted to get to the clinic on time when labor starts. So that's been really fantastic, and we've actually seen that uptake increase dramatically. We have a great video of that on our website. It's really touching, I have to say, and it's really fantastic that you can go back to the community again and say, what are the solutions? Why isn't this happening, and what could make it happen? So I think that's really important. One other thing that I think is often overlooked, and I have to make just a quick plug for it, is women's mental health. And again, I'm a little biased because I'm a clinical psychologist, but one of the things that we see over and over again is that the women's health issues aren't addressed, and when we see increasing needs of mental health services, especially when you see such high rates of domestic violence, mourning, grief, etc. We know that postpartum depression is extremely high for a lot of women. Especially in the developing world. We know it's closely linked to economic status. So one of the things that we've been working on doing is early screening and support. So setting up those support systems, looking at how we can decrease domestic violence, since that's such a huge predictor. In India, we've been working with Sisters of Charity also on residential care. There are a number of homes that they operate for women with mental illness. And traditionally, I think the thinking was that, we're providing a place for them to go. When the family doesn't want to take care of them, we're providing a place for them to go. And it's kind of like out of sight, we're going to make sure that they're cared for and so forth. But really focusing on how do we make sure that these women are living a dignified life. Because they have a mental illness doesn't mean that they can't have a dignified life. So how can we really work on that and work on training the families on understanding what's going on, getting the appropriate treatment, and even reintegrating into the family when appropriate. So I think those are really powerful examples. And I'll share one final story about programming. One of the things that we did in Egypt was actually work with women on village councils. Village councils they're elected positions, and they're run traditionally by men. Women don't usually vote because you have to have an ID card to vote, and most women don't have ID cards. So usually it's the men, and they are coming up with solutions to healthcare issues, education issues, et cetera, other things that are affecting the community. So in Egypt, we actually worked with about 15,000 women to have access to IDs so that they could first and foremost have the right to vote. Then we pulled them together in a lot of different workshops and taught them about the importance of voting and why it's important to have a voice. And did they have possible solutions for the community's issues that they would want to voice within these village councils? And the women themselves actually selected 45 women amongst them to get more advanced training on how they could actually run for election. And 3 of them won. They're actually on the village council. So that's pretty impressive when you consider that before they weren't even voting. So I think there are a lot of things that we can do. I think that if we're collective, if we also look to the communities to be a source of inspiration for us, and engaged in this in a true partnership, that I think the momentum is there and that people are going to be engaged in a lot of different ways. But we have to figure out how we work within the cultural context where we are. We have to figure out how we engage and make this a much larger discussion. So I won't spend too much more time talking about different examples, but just to say that I think there's hope. I think that there are clear examples where this can be successful, not only from our work, but from lots of other work that's been done. And I personally hope that that's the case, because I'm hopeful that by the time my daughter reaches my age, she's addressing a whole new range of issues, and that I can come and listen to her talk and say, oh, wow, look how far things have come. So thank you very much.